Good morning and good afternoon, everyone. Welcome to the second event in our three-part series, Writing the Path, Securing Global-19 Vaccine Equity. My name is Rebecca Weintraub. I'm a physician, a vaccinator, and I lead vaccine delivery and better evidence at Ariadne Labs. I'm also a steering committee member of the Convince Coalition. We at Ariadne Labs have partnered with the Harvard Global Health Institute and the Harvard Center for AIDS Research on this series to elevate the importance of equitable global vaccine allocation and distribution. Our aim is to foster dialogue between global experts about the challenges and paths to securing global-19 vaccine equity. In the last session, we looked at the global picture about inequitable procurement and allocation. Today, in the seminar, we're going to look at how do we think about upstream about the bottlenecks to equitable vaccine distribution, including scarcity and vaccine confidence. Before we get started, just a few housekeeping notes. The session is being streamed and recorded through Zoom, and it'll be made available at the Harvard Global Health Institute website. We'll be running a live Q&A towards the end of the panel discussion, so you've enabled our Ask a Question feature on the bottom of your screen. Please put questions there, and we'll do our best to answer them during the Q&A portion of the seminar. We've also enabled the chat function, which will be monitored by my colleague Luke, and please make sure you set the message recipient as everyone. We'd love to begin with everyone posting the chat from where you are today. Now, with that, I have the honor of introducing our keynote speaker today. Dr. Heidi Larson is a professor of anthropology, risk and decision science, and the director of Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. Her research focuses on the analysis of social and political factors that can affect uptake of health interventions, with a particular interest in risk and rumors from clinical trials to delivery. Professor Larson previously headed the Global Immunization Communication at UNICEF, chaired the Gavi's Advocacy Task Force, and serves on the WHO SAGE Working Group on Vaccine Hesitancy. As a vaccinator, I continue to reread her book, Stuck: How Vaccine Rumors Start and Why They Don't Go Away. Heidi Larson calls on scientists and providers to make engagement authentic. Her research bolsters the evidence that vaccine communication is not served when it's reduced to marketing. Individuals want to have their choices respected, and we must begin with listening with empathy. Dr. Larson, I'll pass the baton to you.
Thanks so much. Let's see, I'll go to the top. Okay, thanks so much, Rebecca, appreciate it. I'm going to do a bit of stage setting, scene setting for our conversation today, and look at building vaccine confidence, looking at the trends, a few suggested solutions, and then we'll take it from there. Some of you may have seen this slide. This was from the FT at the Vaccine Confidence Project, which I founded 11 years ago now. We've been carefully monitoring with all kinds of approaches, from surveys to social media listening, qualitative research on the ground. And this is from a study, 149 countries around the world, with our confidence index, which looks at effectiveness, which is the left, the vertical axis, and then here safety. So you can see that the main point being that there is a spectrum of confidence around the world. And if you put this on a map over time, people would be, countries would be moving across the map all the time. It's a very volatile landscape, which will be a theme of my talk. We've been recently published an analysis over time because actually one of our key interests is how things change. What are the dynamics, how they change over time and space, because you can't rely on what you learned 6 months ago anymore, never mind 2 months ago. And in the context of COVID, it seems to be week by week, day by day. The top is 2015 importance on the left, and 2018 on the right, and effectiveness on the lower band. But just to show you, I mean, the good news is the overall confidence in the importance of vaccines actually has had a boost between 2015 and 2018. And I would hope in the context of COVID, we will be getting more data in later in the year, because I would think that when we see vaccines and the role they're playing with trying to get us back to some semblance of a normal, there would be positive sentiment. But that landscape, that shifts when we start asking about effectiveness, and it's even more fractured landscape when it comes to safety. In fact, here you can see some countries get more confident, but the concerning bit is that in North Africa is becoming increasingly skeptical, and on the safety question, that goes into multiple countries in West and North and West Africa, primarily Francophone speaking. And we do know that France and French media are among the most vaccine skeptical in the world. One of the countries that had the biggest drop in public confidence between 2015 and 2018-19 was Indonesia, actually had the biggest of the 149 countries. And one of the points here is that it just takes one vaccine, experience. Well, I wouldn't say it was a bad vaccine. The experience was really broke confidence when a group of Muslim leaders questioned the religious acceptability of the measles rubella vaccine, concerned that it had elements of porcine and were not halal. That really was a knock on public confidence more broadly. And one of the other points is that confidence is driven by current events, but it's also very much leveraged by historical experiences, and certainly the experience around the MR vaccine campaign, the measles rubella campaign in 2018, 2017, did have a knock on confidence around the new COVID vaccine. But to their credit, the government recognized that it wasn't just the scientific and regulatory board that needed to approve this vaccine before rollout. They went to the Islamic Council. They didn't want to get the Islamic Council putting a fatwa against the vaccine out there. Later, they wanted to have an upfront. So they recognize it's not just about the science, there's a value dimension of what needs support before being introduced in the public. The other country next to Indonesia that had a pretty dramatic drop in confidence was in the Philippines. And that was not the measles rubella vaccine, but a new vaccine against dengue. And that was a real risk that was reported a year after it had been introduced. And it really was a knock on confidence and became a real political drama against the previous administration, who had introduced this vaccine at a time where it looked like a real hope in a hyper-endemic dengue country that really needed a vaccine. It dropped from the top 10 countries out of the 149 to number 70th. It was actually the fourth, from the 4th to the 70th. And that too is having a knock-on effect on the current COVID confidence. So these are just examples of we need to, when we're looking at where we need to be building confidence, not only look in the moment, but look at, have there been previous experiences we should pay attention to? How can we integrate and mitigate such things happening again? How can we make sure we address and spend maybe a little extra time in communities that previously had been less confident? In the Philippines, we've been working with the country since the beginning. We initially measured with our confidence index how much of a drop there was in the confidence before and after. We had our baseline globally from 2015, so we could go in and measure. And as you can see in 2018, the red is negative. And what really strikes me here is that even their perception of compatibility with religious beliefs, dropped considerably. Now, I mean, when you look at it, you think, well, their religious creed hasn't changed. But when I talked to some of the people, they said, well, this is about faith. We had faith in the vaccine and we had faith in the immunization program, and that faith was broken. It was no longer compatible with our religious beliefs. And in that sense, it was more about values rather than written script. And indeed, there's no real old religious text that mentions vaccines because they didn't exist when most texts were written. So it is generally about interpretation. We've been monitoring since 2015 when we called out that Europe was the most skeptical region in the world. The EU has been putting a lot of invested time into trying to rebuild confidence. They have asked us to be monitoring the confidence across Europe since then. We do biannual and sometimes country level assessments. And just between 2 years from 2015 or 3, but from the publishing of the data in 2016 to 2018, we've seen Poland had a significant drop in confidence, and Romania and Denmark also a small drop. But just again to point out that these are very volatile situations that just in 2 years, because of a proactive anti-vaccine movement that was highly organized, embedded in the parliament, that this can have a significant consequence. I just published an editorial in Science a couple of weeks ago on the volatility of vaccine confidence, really talking about how we need to be vigilant. And there's not one moment we should be building confidence in COVID. It's every day, it's every moment. We need to be alert. I often think of it as just being like the weatherman, watching the changing weather and having to shift what our readiness is for. We have taken all of our listening mechanisms, social media, surveys, local collaborators on the ground to shift and listen to what's going on around COVID and COVID vaccine confidence. This was just in December, a 32-country study on willingness to take a COVID vaccine. Again, you can see it's quite diverse. I mean, there's not really 2 countries that are the same. And in some cases, we see that background vaccine confidence, like France, is among the more skeptical around the COVID vaccine. It's not true everywhere that their general routine vaccine confidence is similar to COVID. They can have other issues around COVID different from the general vaccine, but it does give us some background context. What strikes me here and is really important to pay attention to is that across all the socioeconomic demographic correlates that we collect when we do our surveys, when we tried to look at what had the most correlation with positive uptake or willingness, it was a perception that the government was handling the COVID response well. And when they felt that the government was handling the response well, they were much more likely to report high willingness to take a vaccine, more than sex, age, employment, income, other factors. So that speaks to the trust issue. Again, we do national surveys, but we know that this is very diverse at a local level. This was just some of our subnational analysis in the UK. London and Manchester were the most skeptical, least willing, and that is a bit of a phenomenon we see globally, that in urban areas where you have a lot of mobility, a lot of mixed groups, communities, it does tend to show sometimes lower vaccination rates just because mobility differences, access. You'd think it would be easier to get to people. We used to think it was the rural areas that we needed to pay attention to, but actually urban areas are pretty complex, as I think, well, WAFA for sure knows the complexity of urban health. we have been doing multiple waves, recognizing how volatile these situations are. And the pale gray wave 1 was back in June 2020. The wave 2 we did in October, November, and wave 3 was just in March. In general, people started with wave 1 was higher than the second wave, and I think globally, even with other surveys like Ipsos Mori and Kaiser Pew, they also saw this dip in willingness to take a vaccine September, October, and I think that was a perception that in the summer and the COVID was waning a bit. Also, there was not much discussion about vaccines back in June. There was much more focus on lockdown, on masking, on distancing. You know, if you looked at the social media conversation, there was barely discussion on vaccines. It was much more on anxieties about self-isolating and masking and distancing. But in the summer, there was also, or in the I shouldn't say summer because it wasn't summer everywhere, but in the June to September months, there was more and more information coming out about the vaccines and the various candidates and what stage they were at. And with that came a lot more misinformation. So the lower willingness was probably a mix of a sense of less risk, but also more information and misinformation about vaccines. Wave 3, we've seen a bit of a boost in confidence, basically in the US, UK, France, Italy, and Germany. Less so in Germany, and that's probably because Germany and France were among the countries that were early to spot the concerns about the blood clots with the AstraZeneca vaccine, Germany in particular. And so their confidence did not go up in the same way that other countries did. We've also been collaborating with Africa CDC and have done a 15-country study across Africa. Again, you can see that even within Africa, there's huge diversity, Ethiopia being on the very more positive end, and Senegal and being at the lower end. DRC was also here, it's in the middle, but it in a follow-up study, it had dropped and was right next to Senegal. In the bottom pillars here chart, we have the vaccines in general, comparing perceptions about routine vaccine versus COVID. And the bars are perception that vaccines in general are not safe versus COVID vaccines are not safe. So you can see that the COVID vaccines perception of safety is there's much more concern about COVID safety than vaccines in general, which is certainly, it's totally reasonable, understandable. It's less familiar, it's brand new, not knowing. So I don't think I would really not call these people anti-vax. They are asking reasonable concerns and questions. We also did in depth in each country, and what was interesting, we did see in the regions, there was diversity, like in Dakar, Diourbel, these do vary, just another slice of the diversity within countries. Now this data I just got yesterday, this is a very concerning trend. And we've heard this also from a number of other African countries. The issues around reported issues, and the government suspensions of the AstraZeneca vaccine in Europe, the temporary suspensions by some, and the news about the blood clots, which were further confirmed yesterday, has taken a real hit on Africa confidence in that vaccine, which is concerning because it is has been planned to be the main vaccine in the COVAX facility primarily for low and middle income countries. It is more stable, and than Pfizer Moderna in terms of some of the settings it would be used in, but there is growing less keenness for it. South Africa had already said they want to wait for the J&J vaccine because it was more effective for the South Africa variant. But this here, wave one, on the left-hand side, wave one shows 49% of the representative sample across Nigeria, 49% strongly agreed that they would take the vaccine, and that dropped to 25%. And this was in March, when all this news was coming up, and similarly a drop to nearly half on perceptions of effectiveness. Sorry. On the right-hand side is just the proportion of people being surveyed on a daily basis, saying that they would or definitely would take a vaccine. It went from 45 to 48% down to here, 18% of the respondents said they would take the vaccine. This is a very concerning trend. We're watching this closely across Africa and also looking subnationally because, again, we want to see where there are issues. The other factor that is undermining some of the confidence is the perception that, okay, the rich countries got their vaccines and we will get them later. And, just this kind of, perception of next in line rather than being upfront, and that we're talking about equity today. I'm sure there'll be more time to talk about that. I think we have to keep in perspective the fact that while that's true on the one hand, on the other hand, it is remarkable, it's exceptional that this is all happening within a year. It's maybe 12 months later instead of 12 years later, which was the discrepancy between the wealthier and the poorer countries. It has been a tremendous leap in terms of timeframes, but we still have very deep issues of inequity and global sharing that I look forward to the discussion on. Just a last couple slides here. This is a recent report from the World Bank, which is another concern. 128 countries were assessed for their preparedness and readiness for COVID vaccines. Strikingly, the two least prepared domains, which I think should probably have been the first among the higher ones, were processes for vaccine deployment training, like the vaccinators, the people who are meant to be giving the vaccine. Only 30% of the 128 countries had any plans in place for that. That's very worrying. And social engagement communication strategy developed in only 28% of these countries. These are engagement strategies that should have started as soon as we knew there would be vaccines out there. And similarly with training, these are brand new vaccines, new ways of working. We need our frontline vaccinators to be giving confidence, and if they don't have it themselves. So those are two things, just in terms of spotting things that need attention as soon as possible. Those are two. If I have one important takeaway is that we shouldn't be looking at the COVID vaccine rollout as a challenge in itself, but we can change the foundation for building trust more broadly. I started out with the talk talking about the impact of historic experiences. What people experience now will be what they remember when we have more outbreaks to deal with. They will remember it either as a positive experience, or if it doesn't go well, that will certainly be remembered. So we have to handle this with kid gloves and very carefully. And I'm just going to whiz through a few slides of things that I think have been really positive efforts. There's an African alliance, which I'm part of, to capture infodemic issues, positive and negative, and try to get them early, which is a collective effort. It's really been very sharing across different agencies and entities. This is in Singapore. I was really moved by this. This was a young woman who started something there are a lot of different migrant workers in Singapore from different parts of Asia, and there were some serious outbreaks. They thought they had gotten it under control as a country, but it started to break out. And this was it's called My Brother. And in all these different languages, there's lots of resources. They connect them with each other in lockdown, in isolation, very positive, turning that experience around. The Black Coalition Against COVID in the US has been remarkable, engaging Black doctors, nurses, and researchers to engage in their communities, in other places. In some communities, I've seen a drop from 65% saying no way to down to 35%. Only 35% saying no thank you to the vaccine. That's a powerful engagement strategy. I've been working and co-developed as part of the UN Verified project, an initiative called Team Halo, and that's been launched in UK, Brazil, and India. And it's young scientists and researchers who have gotten onto TikTok, answering questions, being engaged, and you get to know these guys in not just in their lab, but you're with them in daily life, and you get to see them as people like you and me, aside from their scientific work. And this is the book that Rebecca kindly referred to. And one of the things that I bring out in the book is that when we talk about evidence, we need to remember that there's many different kinds of evidence that we need to remember. I mean, there's scientific evidence, but there's a lot of personal evidence and experience that people are constantly weighing. And it is the root of evidence is really about testimony and witnessing, and not just massive numbers. And I think this is something to be particularly conscious of as we manage the risks, reported risks around AstraZeneca. This is our website, and thanks very much. I'm sorry I went over a bit here.
No, thank you so much, Dr. Larson. This has just been absolutely tremendous and a wonderful start to the discussion. And reminds us of the spectrum of evidence we need to combat and understand the volatility of vaccine confidence and not being a singular source, maybe quantitative or qualitative data. So now we'll move into our moderated panel discussion. Please post your questions in the Q&A during the panel, and we'll devote time to the last segment to answering them. And thank you, Dr. Larson, for joining us, as there may be questions, multiple questions regarding your presentation. So I will now introduce our panelists. So Dr. Wafa El-Sider is the professor of epidemiology and medicine, the founder and director of ICAP at Columbia University, and the director of Columbia World Projects. She's an international expert in epidemiology and research on the prevention and treatment of HIV, tuberculosis, and other infectious diseases. For over several decades, she's advocated for failing communities most impacted by HIV and championed a collaborative multidisciplinary approach to confronting the global epidemic. Based at Columbia University, Dr. El-Sider leads ICAP's portfolio projects in 30 countries, and under her leadership, ICAP has become a global leader in HIV and health system strengthening. She's also director of the Mailman School Global Health Initiative, which mobilizes the university community to address critical challenges in global health. Since the start of the COVID-19 pandemic, Dr. El-Sider has shared her expertise as a member of the Mayor's Scientific Advisory Council, the New York City Test and Trace Group, and Columbia University's COVID-19 Task Force. Thank you for joining. Dr. Yodi Al-Khaja is the co-chair of the African Union African Vaccine Delivery Alliance for COVID-19 and serves on the Global Advisory Board of Women's Lift Health and is the chief strategist for Convince Africa. Dr. Al-Khaja is the founder of the Nexus Hub, an innovation center, research, social development, and emergency response unit for the West Africa region, headquartered in Nigeria. She's a published researcher, and in collaboration with the World Health Organization, UNICEF, has led multiple country behavioral health surveys across several nations in the Pacific region. She's also the former chief humanitarian coordinator for the government of Nigeria and led the joint national and international humanitarian response in the Lake Chad region between 2016 and 2019. And our moderator, Catherine Bliss, brings her expertise in the social sciences, history, and international relations to her work analyzing US government support for health programs in low and middle income countries. At CSIS, Catherine is currently directing the work of the CSIS LSTHM high-level panel on vaccine confidence and misinformation, and leads the immunization and primary healthcare focused activities within the CS Commission on Strengthening America's Health Security. With that, I'll hand it over to Catherine, who will be moderating the discussion today.
Rebecca, thank you very much for the introduction, and it's really a pleasure to have the opportunity to be part of this conversation. What strikes me about today's topic, vaccine confidence, global trends, and practical solutions, is that we know that the questions, concerns, rumors, and conspiracy theories that undermine vaccine confidence circulate online, through digital platforms, by cell phone or WhatsApp, or just by word of mouth. And we know they have global reach. They're transmitted through diasporas, among immigrant or expat groups, or groups with linguistic and cultural affinities or post-colonial ties. They're complicated too by the all too real challenges of equitable access and distribution. These phenomena, of course, are often shaped by historical experiences of discrimination and broken promises. And yet, to some extent, while all of this is very global in nature, the practical solutions to addressing rumors and conspiracies, to building trust, to improving access, and listening to and addressing people's concerns are really very local and very much rooted in the community itself. But just as communities have a strong role to play in fostering confidence and restoring trust in vaccines, in science, in health authorities, among skeptical people, so too do governments, nonprofit organizations, the private sector, and international organizations have a role. And this is true both in the COVID-19 context with COVID vaccines and in strengthening confidence in vaccines more broadly. So we have a wonderful panel today to explore these questions of vaccine equity and vaccine confidence, misinformation, community relationships, and the role of the international sector in strengthening trust in vaccines. So I want to first invite Dr. Yori Alakija to offer some initial remarks. How are you seeing these issues of vaccine confidence, misinformation, and access play out in your work with the African Union Africa Vaccine Delivery Alliance? And then I'll turn to Dr. Wafa El-Sadr for some initial remarks as well. So Dr. Alakija, over to you.
Thank you very much. I think it's a pleasure to be here, first of all, with you all, and thank you for the invitation and all the hard work in putting this together. I think Heidi has given an excellent background in what we're actually seeing on the ground right now, what the global situation is looking like. What vaccine confidence, your question goes to, or you've asked me to speak both to equity and confidence in a way, and for me, they're very much interrelated. What is going on in a global setting with regards to vaccine confidence, where you're now beginning to hit that confidence war in parts of North America, and you're sort of getting to that last most difficult mile. And what we're seeing in parts of Africa where we have no vaccines cannot be compared. It's just not a comparable situation. And I think, Heidi has spoken about, yes, we do need to work upstream and we do need to build confidence, but we also need to ensure equity. And I think it is completely interrelated in that we don't have confidence in the vaccine rollout across the world because it is not equitable. Because here in the low middle income countries of the world, I was on BBC News earlier talking about, why is there vaccine hesitancy in low middle incomes of countries of the world? What are we hearing regarding to AstraZeneca? What goes on in the north, the high income countries, the global north, affects sadly the global south. Yes, we've seen a difference. HIV, it took 10 years, 12 years for drugs to get to the global south and to Africa and other parts of the world. And therefore we saw about 10 million, more than 10 million people die. It is not okay that it is now only taking a year. We should be able to roll out vaccines to everybody. We're in such an interconnected world. I can watch the same TV program as you, who is sitting in Washington, D.C. potentially, and whoever's sitting in Cambridge today, and Heidi, who's in London, and myself in Abuja. We're interconnected within seconds. We're sending each other messages. And so we have the technology, we have the know-how. What we don't have is a political will. What we don't have is the determination to ensure that we have a more equitable world. And within a world in which we have a serious race against, between the virus, the variants, and the vaccines, surely it is in the enlightened self-interest of the rest of the world to ensure that we do get the equity. Because by the time vaccines, so where it links into confidence is that by the time vaccines get to parts of Africa, like Heidi has just shown, with what we're seeing now, that graph she showed, that the data from the 9th of March in Nigeria, 45% to 18% on the 21st of March. We're now in the middle of April, I think. I mean, the year is going in all sorts of different directions. We're now almost middle of April, and I can assure you that number has dropped further. So how has equity affected confidence in that regard? You have a basket of vaccines in the US. In the US, there's AstraZeneca, there's not even AstraZeneca, there's Moderna, there's Pfizer, there's Johnson & Johnson. So there's some level of choice in the matter. In the UK, ditto. In Europe, ditto. But in Africa, because the COVAX facility is rolling out almost solely the AstraZeneca vaccine, that affects confidence. That is an issue of equity. Because if I feel that you are only giving me the cheapest, most easiest option for you to provide, yet you are telling some of your people, for instance, the UK has just said, nobody under 30 should take the AstraZeneca vaccine. Well, 70% of Nigeria's population are under 30. 70% of most African populations are under 30, and yet that is the vaccine that we're saying is for these countries. So for me, it is inextricable, the issues around equity and the issues around confidence, because until we feel that we're all on the same level playing field, then we can begin to measure, we can begin to do the same level, to use the same measurability index for confidence, say in the UK or in the US or in Europe, as we do in Africa. At the moment, trust is our key issue, and equity is completely linked to trust. Confidence is also linked to trust, and I think equity is that piece in the middle. Over.
Thank you. So, Wafal Sadr, Yuri Alakija has really, put forward.
Did I lose you?
No. This idea of the relationship between trust and confidence and equity sort of underpinning this whole process.
Mm-hmm.
To what extent, but equitable distribution to some extent, preceding vaccine confidence. What do you see? I mean, are these inextricably related? Do they go back and forth? Can promoting greater confidence in vaccines while waiting for an equitable distribution work, or does one really have to precede the other? How do you see this shaping up?
Well, thank you very much. First, I want to thank you for the opportunity to be with all of you and all of you who are attending, and my esteemed colleagues, Heidi and Ayo. And I want to particularly thank you, Heidi. You've been kind of the voice in the wilderness for all those years, trying to highlight the importance of the topic we're talking about here today. Continuing to do this work and shine a light on a very fundamental issue, which is how can we build confidence in vaccines, which are really enormously valuable tools at our fingertips to prevent disease and deaths. So thank you. Thanks to all. And thank you also for Ayo for your enormous efforts, particularly in the African continent. I do think, unfortunately, and I'll get to your question, Catherine, in a minute, but unfortunately, we tend to think in moments of crisis. So here we are in a moment of a crisis where we have these vaccines, and we have, on the other hand, the data that Heidi showed us and also that Ayo mentioned as well. And we're trying to kind of respond to this at this moment of crisis. And it's really unfortunate, because I think what needs to happen is really to be working on these issues during, I call them peacetime, which is the times between crises when we are not experiencing a pandemic, to be working on building confidence broadly in health systems. I think fundamentally, a lot of the mistrust is anchored in mistrust of government, mistrust of researchers, and mistrust of the quality of the health systems that unfortunately in many parts of the world, for some subpopulations and subgroups, is suboptimal and does not deliver the quality of services that people need and actually, and not only do they need, but they deserve to get. So what we need to be thinking about are some of the maybe beyond the answers that people are giving us is the why, and I think it's when we get the answers to why are we hearing this, that then we can problem solve. And hopefully we need to problem solve now, because we're in a crisis mode, very concerned about some of the figures that Heidi showed of decreasing confidence in some countries with availability of vaccines. That's very alarming. But we need to think about the the reasons behind this, and the reasons will vary from community to community, from country to country, within countries, and therefore there's no macro solution. It is going to depend on very much listening to what the concerns are within certain groups and trying to address those concerns. And sometimes we kind of naively think that it's all about knowledge. It is not all about knowledge, as we all know, all of us know. It is about knowledge partially, but it's also about beliefs and belief systems and history, and trust is built over generations and transmitted from generation to generation, or mistrust is transmitted over generations. So I think fundamentally I feel that we need to be thinking of now in this crisis mode of how do we overcome this issue of trust in the health systems and trust in the vaccines. But more broadly, we need to be thinking longer term, on the longer term, and how do we build a truly trusting confidence in our health systems and what it can deliver to people, the breadth of the population overall. So there are certainly, and the other thing is that, you know, when I think back, unfortunately, in the COVID response, we've stumbled. I mean, we've stumbled all along. It's not just in the vaccine launch and the vaccine scale up, but we've stumbled with testing. We've stumbled with access to testing. We've stumbled with the disparity in outcomes with certain groups, people who were dying at higher rates, more severely affected, and so on. So we stumbled in the response. So I think all of these prior errors and mistakes have built up to the point now where that's undermined also the confidence in these fantastic vaccines that we have now at our disposal. And we should have been thinking way back. I mean, we knew last March, not this March, last March, that vaccines were coming. I mean, everybody you talk to, we knew that developing a vaccine against coronavirus is not going to be like trying to develop a vaccine against HIV. We knew it was going to happen. It was going to happen fairly rapidly. But yet we, with the exception of very few people, very few voices, nobody was talking about vaccines, preparing people for the advent of the vaccines and so on. We were distracted with the crisis of the moment, which was mainly about testing and diagnosis and life and death and so on. So I think overall, I feel like we need to mobilize now to deal with the crisis, but think beyond the crisis and think of how do we get into more of the preparedness mode so that we are building this confidence over time. I'll stop here.
Thank you. You know, Heidi Larson, you know, Wafal Sadr has talked about, you know, the problems of the crisis and really, you know, this, you know, bringing all these issues together all at once as a particular challenge around some of the vaccine confidence issues, but also testing and treatment and many of the other issues we've experienced over the past year. You know, there's an expression somewhere about, you know, never let a good crisis go to waste, right? But, you know, what is the, I'm not sure if that's exactly how it goes, but, you know, just wondering if you see, so it's something like that, but if you see in your work any sort of innovations or silver linings in terms of communications around equity and confidence in this particular COVID crisis, whether it's reaching out to adult communities. You know, you gave some of the examples of the some of the different groups that are, you know, the young scientists working to push out, you know, messaging through TikTok and others. You know, what do you see as some of the innovations that may kind of outlast this particular crisis and be more useful as we move toward recovery and preparedness for the future?
Well, I think the sheer effort to have more conversations with people who have questions, to me, if we can keep up that momentum beyond the crisis, it's going to be absolutely crucial, because it's really, I've really been moved by the amount of local community efforts where, you know, here, I mean, in Maryland, there were the barbers and the hairdressers. Here in London, the Bangladeshi restaurateurs have come together. They know they've had some of the worst levels of mortality and infection in London. And, together with some of my colleagues in Team Halo, they've started this initiative, encouraging others to vaccinate, not just for their business, but for the social gathering around the meal. It's been really moving to see little things here and there coming up. But I think that, this is in the context of this crisis, but we can't let go of those conversations. We need to keep them alive and bring other things into it. And that, I think, if there's one thing that the vaccine community should learn, take from this, is don't just talk about the vaccine when you get vaccinated or give a vaccine or promote a vaccine. You need to think about what else is going on in the lives of people and why, and help think about how this situates in that life. And that's an important conversation to keep going.
Great, thank you. Let me turn back to Yuri Alakija. Lessons from the global polio eradication initiative and other global immunization campaigns suggest that a strong bond of trust between vaccinators and the community is important in ensuring acceptance and the success of the program. When outsiders come in pushing a vaccine for a virus or a condition people haven't seen or are not overly concerned about, they're not likely to be very receptive. You've had a great deal of experience working in conflict and humanitarian settings where the levels of trust may be even more fragile than in some of the contexts we've talked about so far. So I just wanted to ask you, to reflect on, what factors can build trust and strengthen confidence, particularly in settings where there are political or social tensions. At this point, 15 months into the pandemic, there are probably political and social tensions everywhere over these issues, but particularly in conflict settings. And how important is it to enlist community health workers in the effort to build confidence about vaccines?
I think, trust, I mentioned this at the top of my comments, that trust is an integral part of what we do, of building confidence, of overcoming hesitancy. And then when you start to talk of those in humanitarian settings, you talk about those in affected by conflict and crisis. In Nigeria, for instance, we have about 20 million people. To be very specific, about 20 million people affected, well, more now, maybe more, about 25 million affected by conflict and crisis. We have almost 2 million displaced people. One of our challenges is, how do we ensure that vaccines get to those people, and how do we ensure that there will be uptake of vaccines from those communities? It is important that, I think from a global level to a regional, then to a local level, that we work very closely with those who are at ground zero of the efforts. Those are communities understand. This was some of what Heidi was talking about. Those are the communities' trust. So she talked about the Bangladeshi community, and she talked about the barbershops and the hairdressers and what have you in the Western world. I think we have to find those equivalents in our communities. But then for those who are displaced, for those who are affected by conflict, even down to non-state armed groups, one of the things that I've been working with closely with colleagues, ICRC and MSF, Médecins Sans Frontières, advocating for, is that we make sure that even those who are considered non-state actors are also vaccinated, because they are definitely vectors. And these are people who move. For instance, one of my as introduced earlier, my past life was a chief humanitarian coordinator for the crisis in the Lake Chad region, which covers Chad, Niger, Nigeria, and Cameroon. And these people move fluidly in between those borders. And if we're going to be really stringent in our controls about vaccinating and not reaching out to those communities, we have to find those they trust. We have to work with people in that instance, like Médecins Sans Frontières or ICRC, who maybe have inroads into those communities. And the global community and governments have to come to a place where they say we are. It's a really strange place. It's just like the international IHL, international humanitarian law principles that say we will provide medical support and we'll provide food for both sides. We need that. That's one of the things I'm hoping will come out of something out of like the Global Health Summit that we're looking forward to in May, that agreement will come forward, that governments will agree that everybody, be it ISIS, be it ISIL, be it Boko Haram, that they will have access to the vaccines that they need. Because again, they have huge influence in huge swathes of Africa, West Africa, Central Africa, and as they do in other parts of the world. And that confidence and that trust, this is where it gets tricky. This for us is going to be that sort of final last mile, because many governments and many institutions are going to balk at the idea of providing this assistance. And yet, if we're to reach even the vulnerable people that they have control over, we're going to have that dialogue even with them. We're going to need to be able to get into those communities. So that is a really, serious consideration in terms of building vaccine confidence. Who speaks to them? Is it radio? We've talked about WhatsApp, we've talked about the various social media mechanisms, but the value of community radio, the value of local traditional methods, theatre. Some of the groups that I'm working with the Africa Vaccine Delivery Alliance, we're beginning to explore the use of community theatre deep in communities, because in capital cities, in Nairobi, in Kampala, in Johannesburg, people are still quite, they're hesitant, but at least they believe that COVID exists. You get into rural communities where, again, the messaging has not really gone down into rural communities. Yet, if we don't vaccinate at that level, never mind areas affected with conflict and crisis, we're not going to reach the desired herd immunity. Wafa said something earlier about each community, and contextualization is how I heard it. And that is going to be really critical in this moment. We have never done this before. We have never had a mass global immunization, vaccination program of an entire world of billions of people. Yes, we vaccinated children. They're about 4% of the people that typically are being vaccinated. But now we're looking at almost the entire global population. And we're going to have to think of building confidence almost in bite-sized pieces. It's going to have to be very context specific, conflict areas. It's going to be rural areas in northern Nigeria that have a specific, going back to the polio that you referred to, that have their own hesitancy issues. It's going to need to be targeted, but there's a fierce urgency of now, because yes, we have equity issues, but we also need to concurrently be building confidence whilst we pressure, the powers that be at global political level to ensure that equity becomes a reality.
Just thank you. I do think maybe to build on what you just said is, there are lessons learned. I think, and I always say somehow we should avoid reinventing the wheel. And sometimes the global health community, we kind of really tend to reinvent the wheel again and again.
Yeah.
And we lose time and effort and lives. And I feel that there are enormous lessons to be learned from the HIV response. There's certainly a lot of similarities between these two pandemics. We're living through two pandemics now, maybe for the first time in history. And they're two viruses. They are both zoonotics. They have both been associated with myths and misconceptions. They've both been also associated with mistrust of authority and mistrust of the health system. And but I think there are lessons learned, and I think what we learned with the massive scale up of HIV services, and I think particularly in Africa, in sub-Saharan Africa, are some principles, and one of them has been community engagement. It's just been from now, one wouldn't even imagine starting a program or thinking of designing or implementing a program without engaging the community, engaging community leaders, engaging people from the community to be at the table in designing that program. You can't walk in with something pre-made and say, okay, here's what must be done. The transformation in terms of bringing the affected communities to the table, bringing the advocates to the table as part of the decision-making, as part of the governance, has been very fundamental to the HIV response. And the success has been enormous over the past years. So I do think we can build on the structures, we can build on the systems, we can build on these lessons learned rather than reinventing the wheel de novo. We can
absolutely
community healthcare workers, and they can disseminate the enormous amount of media use and messaging, and we've the work with the champions, the PrEP champions, the circumcision champions, and so on. So anyway, I think there's a lot on which the vaccine efforts can build on in many of the countries, and that can also accelerate the potential impact if we do so, rather than starting from scratch.
So I want to.
If I may, very quickly,
Sure.
Catherine, I agree with what Wafa's saying, and I think really the reason we have many of these groups across Africa now, where, you know, when we're dealing with HIV, those of us who are old enough to remember those days, when we're dealing with HIV, there was very much a sense of people coming out to the African continent or to other parts of the world to help them teach and to help instruct on what to do. And now we have those homegrown solutions. So it's not at all reinventing the wheel. It is just now that we have the capacity on the continent, and we have the creativity. The innovation is actually been truly amazing. However, we cannot have a development mindset in an emergency situation. And that is, you know, in the language that is going back and forth at the moment, that is beginning to concern me. You know, the way we're beginning to talk about how we're going to plan this in the long term. I mean, for the rollout in America, where I think as of today, it's about 180 million vaccine doses have been delivered. Nobody sat down to think, how are we going to plan how we're going to reach communities? Why? Because there was the funding, because there was a political will, because there was a determination. People just went out there and did it. And so when I start to hear about the planned interventions across Africa and other parts of the world, I was just in another panel just a few minutes ago, as most of you know, with Patty Garcia talking about the situation in South America, which is just critical right now, and that there's very little attention from the world. There's no time for planned interventions. This is different to HIV/AIDS because it's not a slow progression disease. This is a now thing, and there's a fierce urgency of now that we need to capitalize on. And so, in building our confidence, we also need to move agile. We need to be flexible with our systems, and we need to be urgent with what we do, building of what is done before, but working very closely with those who are engaged at community level. We don't need to import. We just need to act. Over.
This, you know, the emphasis on, you know, the urgency, this crisis, this, you know, emergency, and the potential for learning from history and previous, you know, epidemics and the HIV/AIDS response, you know, really, you know, kind of makes me think we're putting a lot of burden on community health workers and the health system. And so, you know, Wafa, I wanted to ask you, you know, I mean, health workers have really been on the front lines of outbreak response, you know, trying to continue doing their normal jobs while also working to deliver, you know, the health services and, you know, respond to COVID while delivering the services that people need regardless of a pandemic. And I mean, there was a poll that came out here in the United States earlier this week that 62% of health workers, you know, say that they are burned out and, you know, just mentally exhausted. And you know, you know, it's become very difficult. And, you know, so I just, you know, I wanted to ask you to reflect on, you know, ICAP's work, you know, in the US, but in countries around the world. What are you seeing in terms of health workers, you know, burnout and mental stress, and, you know, of having this kind of strong bond and really relying on community health workers as the backbone of this kind of response is important. What steps can be taken to support them and, you know, really enable them to provide, you know, to be available for those kinds of conversations and answering questions that is so important with vaccines?
Yeah, no, I think the reality is it's been rough. It's been very difficult in all contexts, actually, what health workers have. Both when I use the term health workers, I'm inclusive of facility and community-based health workers, not just at facility-based and not just what we think of physicians and nurses, but also the breadth of the workforce. And I think all have been enormously challenged by this pandemic, not only through their work, but also personally. They've experienced losses within their own community, as well as losses within their families and so on. So the burdens have been enormous with this virus in particular. I do think that what I'm seeing on the ground is enormous innovations. And that's something that I think many of us underestimate, the nimbleness and the innovations that are happening day in, day out on the ground. And I've seen, for example, really manifestations of enormous resilience by HIV programs and by and people problem solving on the ground, and also ministries of health that have been able to rapidly adapt and adopt new processes so that they're able to deliver the services in new ways, moving to more of community delivered services rather than facility delivered services. Of course, avoid the whole issue of travel during lockdowns to a health facility, as well as the risks, of course, of congregating at health facilities. And also to utilize the community cadres and provide them with the information about COVID, first about COVID-19 and what it is and what it isn't and how it's transmitted and how to protect yourself, but also about the vaccines. So there's been efforts on both sides of trying not to lose some of the hard-won gains for HIV or malaria or maternal child health, while at the same time trying to respond to a new threat through these innovative approaches. I agree that there's not sufficient attention being given to supporting community workers in particular, but I also see innovative approaches to doing so, and the realization that in order to address this pandemic or address any health threat, to be honest with you, you can't sit in the health facility and wait for people to come to you. Is that what we're learning from COVID and from every other health threat is, in order to be effective, you have to have superior high quality services at the health facility, but you have to go beyond the walls of the clinics and the hospitals and engage with the community and the affected communities. And that's where community workers are very fundamental. So there's been this transformation that's been happening over the past several years in order to tackle a lot of the threats that we know about already. And what I see on the ground is a building on this platform to try to do the same, to utilize the same mechanism, the same communication tools and so on to respond to COVID-19. And I mean, it's work in progress. It's a crisis, but we should try as much as we can to build on some of the foundations that exist already in many countries around the world.
Thank you. You know, I mean, we know that so much of the global health workforce is, made up of women. And over the course of the pandemic, there's been a great deal of analysis, focused on gender differences, just, in terms of exposure to COVID through work or family, in terms of vulnerability to severe cases and access to health services, as well as the effect of lockdowns and economic disruptions on women and girls. Several countries have reported increased rates of gender-based violence, pregnancies among adolescents. But at the same time, a lot of the rumors and stories about COVID-19 vaccines center on the idea that they will cause infertility or are part of a larger plan of depopulation of lower and middle income countries. And at the same time, we know that women are often the ones making decisions at the household level about who will get vaccinated and when. And so, this is a question, maybe I'll start with Heidi, because I know I posed this question to you once before about your book, because you have so many interesting stories there about these issues. But how are you seeing the themes of gender and reproductive health and sexuality playing out in discussions about vaccines? Has anything changed? Some of these are long-standing narratives, but is there, what has changed in this context?
Well, I think women have kind of had a disproportionate burden, I would say, in the sense of care and homes. I mean, we see there's data coming out that more women have left their jobs than men during COVID. Partly because of having to do the homeschooling and just manage things that they don't normally, on top of their jobs, they were finding themselves doing more for the kids, as it were, and leaving their jobs as a consequence. There's also been quite an uptick in, certainly here in the UK, and I believe globally, around domestic violence, even the number of deaths that have sadly happened here. I think it's 3 a week or 3 a month. It's pretty dramatic, and I think also, it's the dynamics changing with younger ages getting COVID, but in the beginning, it was really men who were having more serious illness and care needing. So there have been a number of knock-on effects, I think. It's interesting. Women in most parts of the world are less willing to take the vaccine than men, except in Africa. I mean, it's not the same in every single African country, but in general, there's more equity in the levels of willingness to take a vaccine than in some of the higher income countries where women are more skeptical. And I have to want to investigate that more. I think some of it was partly because a perceived sense of being less at risk because of the early stages and what we saw in terms of, the risk of the disease. But I think that also women look much more at vaccine information online because of childhood vaccines, and some of it might be underlying concerns from previous vaccines. Anyway, that's my just quick, not so quick feedback on what I'm seeing. Yeah.
Great, thank you. I want to switch. First, I want to come back to this question and give Wafa a chance to respond as well. But I want to switch just for a moment. Yori Alakija may need to leave us to get back to another meeting. And if Yori, if you're still with us, I wanted to ask all of the speakers, but start with you. In mid-April next week, Gavi, the Vaccine Alliance, will unveil its investment case for securing additional funding for COVAX, which is the vaccine pillar of the ACT Accelerator, focusing on the 92 lower and middle income countries that are eligible for the advanced market commitment. There's a global health summit planned for May, the World Health Assembly, and then a pledging moment for COVAX coming up, I think, in June. So funding obviously is critical for the access and distribution to COVID vaccines, but you can't distribute something if there's no supply or access. But what do you see Gavi, the other COVAX partners like WHO and CEPI and other organizations like Global Fund and UNICEF and others, what can they be doing more of now through their own channels to strengthen vaccine confidence so that when the vaccines are available, they'll be better received?
I think there needs to be a greater focus on delivery. I think within delivery, you have the confidence piece. Can you hear me? Yes. Within delivery, you have more of the confidence piece taken into place. And you talk about COVAX needing, we need to replenish COVAX funding, etc. But the fact of the matter is that COVAX so far has been unable to deliver. Even with what they promised, the initial sort of 20, I think it was 3.3% was supposed to be delivered by April this year. They've been unable to do that. That again has been also due to supply chain issues. And the focus has been on procuring vaccines, not on getting vaccines, as I say, from ports into arms. That ports into arms piece is where the vaccine confidence comes in. It's where the preparation and the overcoming hesitancy comes in. You spoke earlier, Heidi just spoke to the question about the gender piece. And when we talk about gender, I want to go to women and healthcare workers of a certain age who are the majority of the workforce in many of our countries. And many of them, yet the vaccines are not being made available or are not being encouraged for pregnant and lactating mothers. We have no women who are pregnant. There was no trials done on pregnant women. There's no maternal trials done in any study across the world for pregnant and lactating women. So women have been impacted on so many levels by this crisis. I mean, that's not the COVAX question, but I think COVAX and Gavi and WHO and others have to be looking more about the impacts on women. Adolescent girls have suffered a huge amount, and yet they're not, we've had skyrocketing in teenage pregnancy. We've had girls' education has really suffered. So those are the sort of effects of COVID. And when we talk about vaccines and vaccine confidence, we need to ensure that these same girls who are childbearing age or maybe having children are able to have the confidence to go forward to be vaccinated. Yet we don't have any studies. So my first recommendation to the scientists and the Gavis out there, etc., is to fund the research. Specifically, some of what Heidi was talking about, we don't yet have the data. Fund the research. The trials for pregnant and lactating mothers, but also into why women may be less likely to be vaccine compliant in some areas than others. I mean, I think we need to, again, we talk about being targeted. COVAX And Gavi is the entire ACT Accelerator. It's a great scheme, but the tools that are needed to fight this pandemic are not yet available to the people that need them. We don't have diagnostics. You know, I was saying earlier that there was a recent study done in Lagos, Nigeria, that showed that over 4 million people have had coronavirus. We don't have testing. And so most people think they just have malaria. A vaccine is part of that toolkit. Oxygen is part of that toolkit. Until we have the whole toolkit, we don't get the confidence in the system. We don't have the trust in the system. So as we talk about trust and we talk about confidence, we have to put them all in one basket. If I don't trust you to be able to provide me with a canister of oxygen, medical grade oxygen when I need it, how am I going to trust you with a vaccine? You know, this is where, again, and I'm going to end on where I started, the issues of confidence and equity and trust are so interrelated and so intermingled in this urgent moment. We don't have years to get it right. We have a short time. We would like to be getting it right like America has done within, you know, how many days? In President Biden's first 75 days, almost most of the eligible adults are being vaccinated. And those are the sort of timeframes that we have to build confidence, to vaccinate people, and then to look at what I'm sure Heidi will talk about shortly, booster shots, which might be necessary in the future. This thing is not over. And I had an article out in the Daily Telegraph last week where I called it the hidden pandemic. I fear that for some of our countries, Africa and other low middle income countries of the world, the worst is actually yet to come. Thank you. Over.
Thank you so much. You know, Wafa, let me turn to you. I mean, in addition to COVAX, you know, the ACT Accelerator has this health systems connector that, you know, brings in the Global Fund, and WHO, UNICEF is playing a role. You know, what more can the international organizations be doing to prepare and support vaccine confidence and trust more generally in the health system and health authorities?
Yeah, I think that's a great question. I think you might recall that myself and a couple of my colleagues, we wrote a piece that was sort of an op-ed piece in the New York Times, in which we called for the establishment of what we call PEPFAR with a V for vaccines, and that would be more or less kind of a not exactly what PEPFAR did for HIV, but would build on the two elements of what's needed to get an effective vaccination around the world. And one part is I feel, where organizations like COVAX and WHO and these organizations are very good at, which is the procurement of vaccines, the negotiations about vaccines, as well as the normative guidance regarding vaccination. That, you know, WHO is supremely capable of doing this. I do think there's another dimension that has not received as much attention, and that's absolutely critical. So getting the vaccines there is very important, and having that guidance is very important. But what happens on the ground, the vaccination plan, the vaccination program is very, very important. And that we know is more than having a plan, you know, in a beautiful document. That indicates what's planned to be done and so on. It has to be operationalized. And that's where you take a plan into action. And I think there needs to be as much attention, as I think Aya was saying, as much attention to how can the global community working in partnership, because this has to be totally in partnership, in support of the countries themselves, how they can help in terms of that action plan. How do you get the vaccines from the airport when they arrive there to the people who need to be vaccinated? It is not simple. It's complicated. It's complex. There's iterative learning that needs to happen, but it's not impossible. I mean, we've done it. We can do it. And we, meaning the global community and countries, have done it. But it needs to be resourced sufficiently. That component needs to be as sufficiently resourced as the effort for procurement of vaccine is to be resourced. So I think we need to think of almost the two components to this effort, and not lose track of that second very critical piece, which how do you take plans into action? I think that's very, very fundamental, and I think is what often, and that includes within it, of course, the social mobilization, the reaching communities, the engaging of community leaders, the conversations, the messaging. All of this is part of that second piece of a comprehensive plan overall for global vaccination against COVID-19.
Thank you. Heidi, let me turn to you for a second. WAFA has talked about the importance of not just procurement and funding, but distribution and really ensuring a comprehensive process. We know that a lot of countries that, even if they had strong immunization programs focused on children, were sort of struggling, at least at first, to begin to think about how they might reach large adult populations and elderly populations that might not be the ones always coming into vaccine clinics on a routine basis. What do you see, in terms of the role that the international organizations can play and that academic, research institutions as well, partnering with them can offer in terms of, helping to build that capacity for reaching adult populations that have not been as typically, accessed in some of the programs as in the past?
Yeah, I think that actually, when I'm thinking now that in the earlier question where we were talking about where the COVID rollout can build capacity for the future, it definitely is around this life course concept of vaccination, which has been already a growing focus in immunization, and with more vaccines coming up and boosters of other vaccines into life course. So COVID actually has pushed us to be thinking about that a lot more. And I think that that's come up in different ways. How do we do this more partnering with different groups? I mean, academics can do some research on this, but I think there's real life in communities and a lot of, as you say rightly, some of the people, particularly, starting with the elderly, they, especially in the context of COVID, couldn't even go out or shouldn't have gone out. And how do you get the vaccine to them without doing door to door, which, in some cases that was possible. But I mean, I would think that more broadly in adult vaccination, we're not going to be in such a COVID, we're not going to have the contagion aspect in the same way. But, we have some of the worst. Adult vaccination in general is much worse than childhood vaccines. And maybe we'll see better flu uptake after this. We certainly saw in our vaccine confidence monitoring that in 2020 in our EU monitoring, which had been pretty low in previous years on flu willingness, it went way up, 17 points up across a bunch of pretty skeptical countries about flu. And I think they were thinking, well, they better get their flu vaccine because they don't want to get both flu and COVID, because the big boogeyman at the beginning of the year or mid-year last year was we don't want a dual pandemic or a dual epidemic. And you certainly don't want to get both. So I'm probably not answering your question specifically, but you did get me thinking about this life course on vaccines. But I do think we should push our thinking more in terms of these different, how do we get access? How do we integrate this? Because there's a program, around childhood, there's, a routine, there's what did you call it? A little bit of a ritual. There's a ritual around childhood vaccines, which we don't have with adults. And now we're also getting adolescent vaccines, more vaccines in pregnancy. I mean, we should think about ways we can build that ritual, as far as we can. And I think peer support too. One of our problems, though, is less in some cases in these care homes. It's more with the care home workers and the health staff. So that's another topic, which could take a whole other hour. But yeah, I
Well,
hope that was a bit of a reflection, but I don't know if it was specific to the engagement of researchers or others.
no, thank you. It's you know, the issue of rituals, you know, makes me think of vaccine passports. So we've got a couple of questions in the chat that I want to get to. One is around vaccine passports. This has been an issue now that, at least here in the United States, as Yodi has pointed out, I mean, the numbers are increasing daily. There's been quite a bit of discussion, you know, I think around some of the European conversations around vaccine passports, and frustration on the part of other, you know, countries or other parts of the world. You know, well, what if you require vaccine passports for us? What's that going to mean? So, you know, I wanted to kind of ask each of you first, you know, what do you think of the promise and peril of vaccine passports? How do you see that conversation, you know, playing out, as, you know, especially thinking about the map that Heidi showed, you know, that really, you know, put the full levels of vaccination for the lower income countries at 2024, I think, you know, at least as far as some of the predictions. So Yodi, Alakija, if you're still with us, let me ask you to start with that on vaccine passports. But you may have had to step off. So Wafa, let me turn to you, Wafa al-Sadr.
Yes, and thank you. And I mean, I think it's a obviously very controversial issue, to say the least. And I think even the nomenclature is controversial. We usually associate the word passport with going between countries, travel and going between countries. But I think the conversation about these quote unquote passports is much broader than this. It is it's almost, I mean, maybe another nomenclature could be a vaccine certificate or some evidence of having been vaccinated. And I think the concern is that this is being conceptualized not just for travel, which it might be in the future. We all know that we have to show evidence of vaccination against various kinds of conditions like yellow fever vaccination or whatever for travel to some settings. But I think that it's much broader than this. It's being conceptualized as a way for people to have access, to have privileged access to venues within their country. And I think that's what's causing the concern, and I think the ethical dilemmas here. So for countries like, for example, in Israel, where there is a green pass that has been developed, individuals who do have that pass, which is evidence of having been vaccinated, are privileged to be able to go to specific venues, to go to sporting events, to go to indoor dining, for example, at restaurants, and other privileges. So I think part of the concern is that by using or mandating something like this, you are establishing essentially a privileged group and a non-privileged group. And it's particularly difficult, I believe, at a moment of scarcity. I mean, I think even in the United States, we have a long way to go until there's substantial coverage, full coverage by vaccines. And then when you look at other countries in the world, they have so much further to go, particularly many low middle income countries. So even within a country at this point, like the United States, there is a group that has been vaccinated that will be considered privileged, and there's another group that will not be privileged. And that, unfortunately, sometimes includes people from certain ethnic and racial minority groups who have had trouble accessing vaccines for a variety of reasons, but also may also be groups that have more of the wait and see attitude, more of the hesitancy that we've been talking about. So, and also the other issue is there's a mismatch between demand and supply. We have much more demand than we have supply of vaccines, almost universally, which again makes it very difficult to put in place a system where you're privileging the people who have been vaccinated. And that's just these are just the kind of public health concerns, but I do think there also, of course, are the other logistical concerns in terms of just the security of these whatever digital methodology is used. Is this going to generate even more hesitancy, or is it, there's some people who are saying that requiring these kinds of passports or these kinds of green passes may motivate some people to get vaccinated so they can actually be privileged group and they can get access to venues and so on. But there's also at the same time the opposite concern that as you mandate the need for these, you may drive people away because they feel that this is an imposition of some requirement, some mandate that they disagree with. So it's a complex issue, but I'm seeing more and more, I think, as you can see from locally and globally, there's much more conversation about some sort of certification of vaccination that will be required for specific activities. So it's a tough topic, and we need to dissect it as a community and make sure that all the security measures are in place if this is the way to go. But also, I think we need to not jump into this when we are in a moment when there's scarcity of vaccines and disparities in vaccine access.
Thank you. You know, Heidi, we're coming close to the end of our hour. I know Rebecca has some final remarks, but you know, just the vaccine passport issue has been one of many that has circulated on the internet and you know, through social media platforms. Some of the platforms like Facebook and Twitter and some of the others have taken deliberate steps to classify and label, you know, what they call harmful material. This might not fall into that, but you know, thinking about some of the broader rumors that are circulating around microchips and some of the others, you know, how, just kind of a last question, how do you see, you know, health workers and others really communicating with patients and with the community about this kind of online digital information? How can they kind of help people understand what they're seeing, you know, whether it's appropriate or not?
It's specific to the passport.
Well, the passport is one of, you know, many different narratives that you know, are circulating online, and you know, as you pointed out, I mean, there are many people have, you know, lots of, you know, realistic questions, but there are also other stories.
Yeah. Well, I mean, I think when it comes up, if it comes up, I mean, we're seeing a lot of narratives out there that are quite really afraid of the whole COVID passport thing. I mean, it's not they're not ideological, you know, libertarian. They're afraid. It's interesting to see that motion coming out, but there are other. I guess when you talk to somebody, if you're talking about vaccination or whatever, and something comes up, because you wouldn't otherwise know it if they didn't bring it up in a conversation or somehow, that you hear them out and try to. I mean, the main thing is they won't let go of it unless they get a better story. So yeah. I really, one thing that drives me nuts is this debunking end of story approach. Like, you know, it's you can't wipe something out and not put something else there, because then they'll end up back where they started. You need to fill that space with a better story, something that is plausible in their frame. So I think hear the story, hear why they believe it when it seems, and then maybe we can get to something else that's behind it. And if they have that underlying concern addressed, they'll let go of that misinformation. But I think the misinformation, the fact checking bit, I think is important. Of course, we want people to have the correct facts, but there's a lot more going on. I think that Wafa brought that up very early in the discussion. Yeah.
Well, I want to thank Yodi, Wafa, and Heidi for a wonderful conversation and really thought-provoking and wide-ranging. I've been delinquent in letting this conversation run a little too long, so let me turn it over now to Rebecca. But thank you all very much.
Thank you, Catherine. And just a few final thank yous to close out the session. Catherine, Yodi, Wafa, and Heidi, really thank you for a nuanced dialogue to promote vaccine confidence in the midst of scarcity. And our teams have been reading and referencing your work, and we're very grateful for your leadership at this time and eager to amplify your expertise. Second, I want to thank Luke and Carissa, who organized this panel A to Z. Thank you so much for bringing together such a diverse group of listeners. And finally, thank you to our listeners for joining us, and we'll hope you'll join us on Thursday, April 29th for our third and final webinar, Reimagining Pandemic Preparedness, Making Equity a Strategic Priority. You'll find the link in the chat or on the HGHI website. Thank you all for joining us this afternoon or evening and for your interest and for the dialogue.